What years were you at Mass General, Don?
I was there from 91 to 2004.
Okay. Trying to remember when I left. Probably before you came.
I think so. Yeah, I don't think we overlapped. About which I'm sorry. But it was great, you know, Roman and Bill Deck and just the whole.
Yeah, no. It's when I would go in at night, because that was the only time I could get on the computer, is log on and you'd see like half the division is logged on doing research at 11:30, 12 o'clock, 1 o'clock at night. It was
exactly
kind of an amazing place.
Yeah.
So you have a chat here from Mark Huffman.
I saw that.
To all panelists, break a leg.
Thank you, Mark.
We'll have to see later if his ears were burning.
Exactly, Mark, we were already talking about you.
All right, by my watch, it's about 8 o'clock. Should we go and get started? All right, let's do it. Good morning, everyone. Welcome back to Grand Rounds here for the Department of Medicine at Washington University. I'm John Hickman, one of the chief residents. It's my pleasure, as always, to welcome you to our Grand Rounds. On behalf of our chair, Dr. Frazier, Dr. Costco, Spencer, and myself, it's a pleasure to have you join us. I am very excited for our talk today. We have a very special speaker honoring the Guller family. I want to give you just a couple updates. As always, please remember to head over to our YouTube channel, our Department of Medicine website, where you can check out past talks. In addition, as always, if we have time allowed, I will be moderating the chat and Q&A with our speaker at the end. So please send any questions you have as we go along, and I'll pose them to the speaker as we go. And again, here to welcome our speaker, we have our very own Ada Steininger, Professor of Medicine in the Division of Cardiology, Dr. Douglas Mann. Dr. Mann, thank you.
So thank you. It's a great pleasure this morning to introduce the speaker for the 11th annual Guller Lecture, Family Lecture on Cardiovascular Disease Prevention. Just a quick word about the Guller Lecture, and Keith has given me permission to talk about this. So Keith first became aware that he had coronary disease after he became syncopal. And then right now he's doing exceedingly well, but one of the goals of both Keith and his wife, Cindy, was to educate young physicians on the importance of preventing cardiovascular disease. So really over the last 11 years, we've had leading luminaries in the field of cardiovascular disease prevention come in and talk about various aspects. And so that's a wonderful segue today to introduce Donald Lloyd-Jones, who is one of the leading lights in cardiovascular disease prevention. He's the Eileen M. Full Professor of Heart Research and Professor of Pediatric Medicine and Pediatrics at Northwestern University. Don has been here as a visiting Grand Round speaker before and gives a remarkable lecture and is incredibly clear. So Don, we're so grateful to have your presence today. I wish it could be in person, but we look forward to learning from you. And with that, I'll turn the stage over to you.
Well, thank you so much, Doug. It's really a pleasure to be here. I'm so honored to be invited to give the Guller family lecture. And I see that Mr. and Mrs. Guller are on. I'm so grateful that you have the vision to support these kinds of activities. This is an incredibly important part of medical education and continuing medical education, that we share our science, share our thoughts, and share our views on what can be better about the practice of medicine. And it was really such a pleasure to learn about Mr. Sidney Guller, I guess your dad and your family, and all the support that you've done for young people as well with scholarships at WashU, and I'm sure other places too. And just want to again say how grateful we are for supporting young people. It's such an important part of the process. And so thank you for all that you're doing. And again, just a real delight to be here and an honor to give the Guller family lecture. So thank you for your support. So let me go into presentation mode. I hope you're seeing my slides in presentation mode. Everything look good? Okay, terrific. So we will get rolling. As you heard, I'm going to talk today about the life course of cardiovascular health. a specific definition of cardiovascular health, which I'll introduce to you, and talk about it really across the entire life course. And I have no disclosures. So obviously we've known about the major cardiovascular risk factors. They've been on the books and quite accepted ultimately since the 1960s and 1970s. But actually here in our department in Chicago, since 2000, we've been trying to think about this a different way. You know, our founding chair, who I'm going to talk about in a moment, really helped us understand that the best way to understand healthy longevity is to study people who have healthy longevity, people, you know, who live late into life with excellent health. And so that takes the study of large populations, because not that many people in our society are able to achieve it. But he taught us that we should start to think about the risk factor paradigm by flipping it on its head and looking at those people who maintain really optimal levels of risk factors late into life and what that might mean. And so as a result of a body of work that I'm going to share with you today, in 2010, the American Heart Association actually helped us take a major step forward by commissioning almost a definition of cardiovascular health. What does cardiovascular health actually look like? Not just the absence of disease, but something that we can actually all strive towards. And I was really fortunate to be commissioned to be the chair of this writing group. It is a who's who of the American Heart Association, really stellar volunteers and thought leaders in this area. And so we were specifically asked by the board, can you define for us a construct of cardiovascular health where we can measure it in people and in populations, we can monitor it over time, and hopefully we can intervene to modify and improve it. And that's exactly what this document lays out. If you're looking for a soporific, if you're having trouble getting to sleep some night, I think this is a really great way for you to drift off. But what's contained therein is, again, this sort of construct, and the framing context of it is that we really appreciate that health is a broader and more positive construct than merely the absence of disease, right? Cardiovascular health is not just, oh, I don't have cardiovascular disease. But we also recognized that we needed an evidence base that would help us link to good outcomes, CVD-free survival, healthy longevity, better quality of life, things like that. We also wanted to create a construct that was pretty simple and very accessible to the people who matter, especially consumers, so that they could actually find actionable items to improve their cardiovascular health and improve their outcomes across the life course. And as I mentioned, the 3 M's: measurable, monitorable, and modifiable. So those were kind of our boundary conditions for defining cardiovascular health. And then we went to the literature and we reviewed those things that we thought were relevant studies that could inform us. And the first one that came to mind, not surprisingly, was this study from Dr. Jeremiah Stamler, published in 1999. And Dr. Stamler was the founding chair of my department, and I have the honor of being the chair currently of his department. He founded our department 50 years ago, and just passed away 2 weeks ago, yesterday, at the age of 102. And so I want to take just a moment to acknowledge Jerry's contributions to the fields of cardiovascular epidemiology and preventive cardiology. Jerry was widely acclaimed to be the father of both of those fields. He had started his work in the late 1940s in the lab of Dr. Louis Katz, feeding cholesterol to chickens. Now, chickens don't usually get atherosclerosis, but if you feed them high cholesterol chow, they do. And so he took those observations, pivoted to doing some of the first really large-scale human studies of diet and outcomes, and very quickly understood just how critical diet was to the human health condition. And for the remainder of his career, not only did he personally pursue a Mediterranean eating pattern, which is why he, I think, lived till 102 and was literally working on a grant renewal 3 days before he passed 2 weeks ago. But also, you know, I think it really indicated the depth of his character and his commitment to really ideal science. He was an incredible scientist. He enrolled tens of thousands of individuals in his studies to understand the impact of diet on health. And, you know, was really one of the leading lights in defining those traditional cardiovascular risk factors that we now take for granted, all the time swimming upstream. fighting against the Salt Institute, the Meat Institute, and pretty much every other entrenched interest in this area. So I'd love you to learn more about Dr. Stamler. He was a hero of mine. He's had wonderful obituaries published within the last week or two in the New York Times and the Washington Post. And I think truly has saved millions of lives around the globe. And you probably never heard of him, which is a testament to his character. He was a very humble, but very, very profound person. So I hope you'll go learn a little bit more about Jerry. At any rate, he was the one who taught us to kind of flip this risk factor paradigm on its head. Having defined it, he now wanted to learn more about it by looking at the obverse. And so he said, okay, in our large scale studies, can we find those people who maintain optimal levels of cholesterol, blood pressure, don't smoke, don't get diabetes, and don't have any evidence of underlying cardiovascular disease? And how do those healthy people do? What do their outcomes look like? And sure enough, what he found was that those people who maintained all optimal risk factor levels into midlife had markedly lower rates of cardiovascular mortality, markedly lower rates of all-cause mortality, and lived substantially longer. So these were the kinds of data that really were helping us think about, well, what should cardiovascular health look like? This package of optimal levels of risk factors in midlife was kind of an emerging theme, no question. And I was aware of Dr. Stamler's work when I was still at the Framingham Heart Study. And so we tried to replicate it in a sort of slightly different way using different methods, applying lifetime risk methodology, as you see here. And so in Framingham, we said, okay, what do people look like when they reach their 50th birthday? And then what are their remaining lifetime risks for developing a major atherosclerotic event? And what you can see is that for men or women on their 50th birthday who had 2 or more major risk factors, 50 to 70% of them went on to have a major atherosclerotic event before they died. And even those people who had 1 risk factor that wasn't quite at optimal levels had lifetime risks that were quite high at roughly 30%. But here were the special people, those people who on their 50th birthday had maintained that package of optimal risk factors that Dr. Stamler had defined. Notice, almost abolished their remaining risk for developing cardiovascular disease during their lifespan. Sub 10%, down around 5% lifetime risks for cardiovascular disease. Really nice outcomes, very special group, not common, but a very special group of people clearly in terms of their outcomes. And then in parallel, Dr. Mayer Stampfer at Harvard said, okay, yes, risk factors, what about lifestyle? And so he put together a package of lifestyles using data from the Nurses' Health Study to say, could healthy behaviors also be contributing here in a package? And sure enough, he looked at women who were non-smokers, participated in moderate to vigorous activity at recommended levels, maintained a lean body weight, had a healthy diet. And here's the good news. Actually, they've defined a healthy eating pattern as including at least half a glass of wine per day or the equivalent. And what they found in terms of outcomes for coronary heart disease over the ensuing 15 years or so was that the more of those healthy behaviors you pursued, the lower and lower your risk for developing coronary heart disease. So for us on the writing group, these types of data sort of made it clear that we needed to think about a package of optimal lifestyles and optimal risk factors that could really point the way to a very healthy future. And that's how we define cardiovascular health, using these 7 metrics, now called Life Simple 7, 3 health behaviors, 4 health factors. And while there is that ideal out there, we also recognized that there is a full spectrum of cardiovascular health. And so we defined each of these 7 metrics as poor levels, intermediate levels, or ideal levels, based on the existing clinical practice guidelines at the time. So using thresholds there. And I'm not going to walk you through these definitions. The point here was to say that if you have a poor metric, we want to make it at least intermediate. If you have an intermediate metric, we should strive to help patients make it ideal. And in practice, one of the ways this has come out as people have kind of dug in on this construct of cardiovascular health and Life Simple 7 is we can use a very simple scoring method. Simply count how many of these 7 metrics are at ideal levels. That gives us a 0 to 7 point score. But really, even stretching it out more, we can apply a 14-point scale where you get 0 points for every poor metric, 1 point for every intermediate metric, 2 points for every ideal. Simply sum up those scores and you get the kind of broad CVH score. And so you'll see as I go through the rest of the talk, as we've learned more about this CVH construct, you'll see these point scores kind of popping up from time to time. So to cut to the chase, having good cardiovascular health is a good idea. Cardiovascular health status has been associated with a number of outcomes: poorer cardiovascular health status, more adverse health outcomes, higher cardiovascular health status, substantially better longevity, healthy longevity, and all sorts of other favorable outcomes. And you can see it's also associated with things that might be a little surprising. Incident cancer, much lower if you have high cardiovascular health. Maybe not surprising because of the common soil of risk factors, but things like end-stage renal disease, cognitive function, mental health variables, well-being variables like quality of life, and then we'll talk about things like compression of morbidity and healthcare costs as we go through some of the data. So let's talk about, kind of dig in a little bit on the outcomes of high cardiovascular health. And I'm going to kind of walk us through the life course backwards. We're going to start with the studies that have looked at older people, and then we're going to move earlier and earlier in the life course to see, when does cardiovascular health matter, right? When should we really make sure that we are achieving and maintaining the highest levels of cardiovascular health that we can? So this is kind of the rubric I'm going to use. Again, I'm going to kind of go bottom up in showing you some of the data around cardiovascular health, but you'll see this again from time to time as we move through the life course as well. But this is kind of our model for how cardiovascular health comes into being, and then what it leads to in terms of health outcomes. Okay, so these are data from the MESA study, the multi-ethnic study of atherosclerosis. About 6,800 individuals, mean age of about 65, and followed at this point for about 15 years of follow-up. And notice what you see is that across that 14-point cardiovascular health score on the x-axis, there is a very linear, log linear relationship. The higher your cardiovascular health score, the lower your risk for subsequent cardiovascular events, again, in older population. Moving upstream in the life course a little bit, these are data from the Atherosclerosis Risk and Community Study, now a mean age of about 54 in this study. And what they found was, using that 7-point score, the more ideal cardiovascular health metrics you had out of 7, the lower and lower your risk. So notice people with 0 were at the highest risk. Just having 1 ideal cardiovascular health factor compared to 0, 36% lower risk for coronary heart disease, cardiovascular disease over the ensuing 20 years. And then a nice stepwise dose response. The more ideal metrics you have, the lower and lower your risk. And if you had all 7, while that was rare, if you had all 7, 0 events among these about 400 individuals over 20 years, which is quite a remarkable statement if you think about it. So there's clearly a powerful dose response here. And what was nice about this paper as well is they said, okay, is it the health behaviors? Is it the health factors? And the answer is yes. It didn't really matter whether one health behavior was better or one health factor was better. Any of them being better in a stepwise fashion was associated with better outcomes. So again, if you had 6 or 7 at ideal levels down here in this bottom right corner, that had the very lowest risk for subsequent cardiovascular events. And if you had 0, that was the very highest risk. And a nice, again, stepwise production or stepwise lowering of risk with each improved health factor or health behavior. So all the things are contributing. Moving upstream even further in the life course, now we're talking about young adults. These are from the Cardia study of young white and black adults, mean age of 25 at this point. And using the 14-point score, you can see Cardia has nice long-term follow-up of these young adults. You can see very low event rates in the blue for people who have a high cardiovascular health score, meaning the best levels of cardiovascular health, and much higher event rates in those people with low cardiovascular health scores. Remember, these people are 25 at the time we're giving them their cardiovascular health score points, if you will, followed now for 30 years. So all of these are premature cardiovascular events. And this cardiovascular health score, which tells you nothing about their genetics, is pretty powerful at telling you what their risk is going to be for premature events as well. And in fact, here you see the stepwise hazards ratios for moderate levels of cardiovascular health or high cardiovascular health, 86% lower risk for premature cardiovascular events if you had high compared with low cardiovascular health. And the population attributable fractions running between about 55 and 75%, meaning if we could snap our fingers and make all those people with low or intermediate cardiovascular health suddenly have high cardiovascular health, we would abolish, in this simulation, we would abolish roughly 2/3 of all those premature cardiovascular events. So pretty powerful suggestion that this is, you know, even earlier in life is mattering. And sticking with these kind of young adults, this is a very recent study that we published with some colleagues in Korea, looking at a very large database linked to insurance and health outcomes from insurance. 3.5 million Korean young adults at a mean age of 31, as you see here, followed up for about 16 years, lots of events in this very large cohort. But they were also assessed more than one time. So they had a baseline cardiovascular health score assessment and then follow-up cardiovascular health score assessment 2 to 5 years later. And they found some interesting things in this large cohort, which again, really helps to have that many people to follow. Notice a very strong inverse relationship again between the baseline cardiovascular health score, 0 to 7 in this case, excuse me. And again, that sort of inverse dose response relationship between more cardiovascular health things at ideal levels and lower risk. But as I mentioned, they also were able to look at change. So what you see here on the y-axis is the baseline cardiovascular health score. On the x-axis is the follow-up score 2 to 5 years later. And then the top line within each of the cells is the hazards ratio. So what you'll see is that anything above the line here represents someone whose cardiovascular health score improved over time. And notice in every single one of these cells, when the cardiovascular health score improved, the resulting risk for cardiovascular disease was substantially lower. So anywhere from 32% lower to 83% lower if you improved your cardiovascular health score over 2 to 5 years. What's also interesting, I think, about these data is that this bottom row shows you that here are people who had very high cardiovascular health early in life, and they lost it. Their cardiovascular health score actually worsened over time, and yet they still maintained much lower risk. So the earlier you have your cardiovascular health, the better it's going to be. It's never too late, as we see. Change is important. Change will lower your risk, but the earlier you make that change, the better off you're going to be. Okay, let's move even further upstream now. So this is a synthetic cohort of individuals followed from multiple studies across the globe, starting at age 8 and then followed up till midlife. And what we saw here was that using a clinical cardiovascular health score, in this case, the range is from 0 to 8, excuse me, I have a little frog in my throat. We looked at the trajectories of the cardiovascular health score over time. And the data told us that there are kind of 5 different groups of people across the life course, the early life course, in terms of what their cardiovascular health looks like. So I want to walk you through this. Notice that there's a group of individuals who start with quite high cardiovascular health score on this metric. Some of them maintain it into midlife, that top black line we call high with a maybe late decline. Some of them have a quite early decline, so they're high early but decline early as well, that sort of gray line. And then this blue line, start high and then have an intermediate or moderate decline over time. But notice the orange line here, there are people who start with lower levels of cardiovascular health and then do have some decline across the life course. And then these kids at age 8, 3rd graders, already declaring themselves to be in a very poor cardiovascular health trajectory, as you can see, already substantially lower points, and it drops off very quickly through the remainder of their midlife span. So, while some of these kids have already declared themselves by age 8, there are also changes that occur. So sorry. There are also changes that occur across the life course. So then we asked the question, well, do these trajectory groups matter? And of course, this is such a young group of individuals. We don't have a lot of cardiovascular events yet, but we were able to look at many of them had carotid IMT measures at an average age of about 30. And what you can see is that your membership in a trajectory group of cardiovascular health score was strongly associated with the thickness of your carotid IMT at about age 30. So those people with the highest cardiovascular health that held on to it the longest had the thinnest IMT. Those people who already by age 8 had poorer cardiovascular health and lost it quickly had very much the thickest. And this kind of a range, a difference of 0.08 millimeters, if these people were in their 50s and 60s, that would be associated with at least a doubling of risk for cardiovascular events. These people are only 30, and we're already seeing this dramatic difference in their atherosclerosis burden. So really, I think quite striking. Okay, so I've walked you back on in terms of the outcomes from the oldest to our youngest populations where we studied cardiovascular health. I think you get the point, right? This is a good thing. It's probably not too surprising that having optimal levels of the risk factors is going to be associated with good outcomes. But what are the implications of that? So I want to introduce you to a term called compression of morbidity. And I'm going to do it in a study started by our Dr. Jerry Stamler now about 55 years ago, the Chicago Heart Association Detection Project and Industry, 40,000 individuals employed in Chicago area businesses. Excuse me, and now followed for, as I said, up to 55 years by linkage to the National Death Index, but also linkage to Medicare outcome files. So we started following these people at roughly a mean age of 42, but I'm going to show you outcomes once they become Medicare eligible from 65 on. So we're going to characterize them on their cardiovascular health in midlife at age 42. We're going to look at their late life outcomes as they become eligible for Medicare. So in this slide, what you see is horizontal bars. This is people with 2 or more major risk factors at roughly age 42. This is people with that nice package of traditional risk factors in midlife. The dimensions of these horizontal bars are the total bar is their Medicare lifespan, how long they live after age 65. And the green part of the bar is what we call their health span. How long did they live on average free of cardiovascular disease? So what you can see is that for people with 2 or more major risk factors in their 40s, they had, click through and show you the numbers. They had a health span of 76 years. They had a lifespan of 84 years. So they spent on average 8.3 years or 43% of their Medicare time with at least one cardiovascular comorbidity. And the folks who had back in their 40s all favorable cardiovascular health levels lived to age 83 with no cardiovascular comorbidities on average, died on average at age 88, and spent only 5 years on average with a cardiovascular comorbidity. So only 20%, 23% of their Medicare time. This is compression of morbidity, meaning we know that people are going to have to die someday, but we want them to get sick as close as possible to the end of life and compress their morbidity so that they have a much longer health span. And so when you look at the data here, having higher levels of cardiovascular health, having the favorable package of risk factors in your 40s was associated with a 4-year longer lifespan and a 7-year longer health span with regard to cardiovascular comorbidities. So you're thinking, okay, so you don't get as much cardiovascular disease, but that means you're eligible to get cancer or dementia or rheumatologic disorders or DJD, all those other sort of comorbidities of aging. Well, in fact, because we're dealing with Medicare, we can look at those other comorbidities as well. And sure enough, there's nice compression of morbidity as well when you look at cardiovascular health status in the 40s and outcomes much later in life with a 4-year longer lifespan and a 4.5-year longer health span, even considering things like dementia, cancer, and those other chronic conditions. So really kind of an interesting way to look at things. And now you're saying, well, Don, they're living longer, we're gonna have to spend more on them. And the answer is no, because we have the Medicare data. We can actually show that those people with all favorable risk factors back in their 40s, we end up spending across their Medicare lifespan about $75,000 fewer per individual across their Medicare lifespan because of what their cardiovascular health status looked like back in their 40s. So I think really nice indication that, you know, these people require less healthcare utilization, even though they're living substantially longer. Okay, implications. Well, clearly, if people have prevalent risk factors in middle age, we need to do everything we know how to do, lifestyle medications, whatever else is needed to help prevent their cardiovascular events and reduce their risk. But what these data suggest to us is that we do even better if we move upstream and don't let them get the risk factors in the first place. And this is a newer construct called primordial prevention. You all know what primary prevention is. It's treating risk once it exists. Primordial prevention is don't let the risk factors develop in the first place. And I think I'm hopefully making a case to you that that can be a pretty powerful way to transform our approach to preventing cardiovascular disease. Okay, what would happen if we could magically snap our fingers and take away the low cardiovascular health or even the moderate cardiovascular health in the population? One of our former fellows, actually a mentee of Dr. Mark Huffman, asked just that question. And so using, again, large data sets, we were able to simulate what would happen if we were able to transform people from moderate or lower cardiovascular health into people with high cardiovascular health. And what he showed was on this curve that if we could actually magically snap our fingers and remove all low and moderate cardiovascular health, make those individuals all have high cardiovascular health, he estimated that we would reduce the number of cardiovascular events in the United States by 2 million each year. 2 million fewer cardiovascular events each year if we magically made all adults have high cardiovascular health. And even if we were only to get 50% of those people to have high cardiovascular health, we would reduce by about 900,000 events each year in this country. That would be a pretty remarkable transformation, pretty remarkable cost savings, because we are approaching somewhere in the neighborhood of $450 billion per year just spent on cardiovascular care and cardiovascular events. So pretty important numbers we're talking about here. A really interesting kind of way forward. Okay. So hopefully I've convinced you about the outcomes. How does this work, right? Is it just, okay, these people don't have risk factors so they don't get disease? Well, yes, but it's a little more complicated than that. So let's dive into the mechanisms a little bit. Okay, so these are data going back to the MESA study of older adults. And we, again, characterized people using their 14-point cardiovascular health score, which you see here. And sure enough, as you might expect, people with high cardiovascular health have less coronary artery calcification. They have, if they have coronary calcification, they have less coronary calcification as well. So lower prevalence, less overall burden. They have thinner carotid IMTs at older age, as I showed you earlier, at younger age as well. And they have a lower left ventricular mass index. So definitely a lower burden of subclinical cardiovascular disease, which we know means they're going to have fewer cardiovascular events. So kind of makes sense, right? It's working through the pathways that we know about. Okay. But there's some other things going on here too. And these are some data from what we call our Chicago Healthy Aging Study, which is a spin-off cohort of that Chicago Heart Association project I talked about earlier that Dr. Stamler had started. We invited back, at about 40 years of follow-up, we invited back people from the original cohort. So we knew what their cardiovascular health status had been 40 years earlier. And we put them in the MR scanner. And we did non-contrast imaging of their coronary tree. And as you see here, we're able to kind of take cross-sectional slices of their left main, their LAD, their right coronary artery. And so this is a gentleman who 40 years prior, at age 32, already had elevated cardiovascular risk factors. And when we look at the cross-section of his left main coronary artery, you can see the lumen, the black part here, is actually quite small relative to the thickness of the wall of his coronary artery. That tells you there's some plaque here. And if you look very closely, you can see this low attenuation area in the wall of the coronary artery. That's probably, based on other studies, lipid-rich plaque. So the asymmetry, the small lumen compared to the wall thickness, and this low attenuation area on the MRI tells us this person has a pretty significant burden of atherosclerosis in his coronary trees. He's still asymptomatic, but he's got a lot of atherosclerosis. And you see the same kinds of things in his left anterior descending and his right coronary arteries. Now let's look at someone who had an optimal profile 40 years ago. So this is now a 70-year-old man, 40 years ago, had high cardiovascular health, optimal profile. Notice what his left main looks like in cross-section. Big lumen compared to the thickness of the wall. That's a good thing. His LAD looks pretty similar as well. The right is a little bit irregular and a little bit thickened and maybe a little bit of low attenuation. So he's not perfect, but he certainly has a lower burden of atherosclerosis. And when we actually quantified this across about 400 individuals that we were able to scan, what we found was that, to cut to the chase, what we found was that people with high cardiovascular health status 40 years ago in midlife do develop atherosclerosis. Their walls are not as thin as young, healthy people. They have atherosclerosis, but they have much less irregularity, much less thickening of the wall, and they also have much less of those low attenuation areas that I pointed out to you. So yes, they're developing atherosclerosis, but it seems to be much more benign. And so our working hypothesis right now is that, in fact, maintenance of high cardiovascular health does prevent some atherosclerosis, but maybe it also promotes that the atherosclerosis you get is more benign. It's more sclerosis and less athero. And that's why it doesn't lead to as many events. And we're following this up with some other studies right now that I think are going to be very interesting and informative to see whether our hypothesis is correct. Okay, so moving a little bit further on into the mechanism realm, why does cardiovascular health bestow these really great outcomes on us? Two studies from Framingham and Mesa, I think, are also somewhat informative here. So the first study came out a number of years ago from Vanessa Xanthakis at the Framingham Heart Study. And what she showed was that for every one higher cardiovascular health score, every one higher point that people had in Framingham, their risk was 23% lower for cardiovascular events, adjusted for age and sex. So then she adjusted for the most important biomarkers that they found in the Framingham database that were associated with events. And while that attenuated the relationship, now only a 16% reduction per point higher CVH, it was still significant. And then she said, okay, let's really try to knock this out. Let's figure out if we can put in all the pathways that are important here, we should be able to knock out the cardiovascular health relationship. So she put in subclinical disease measures also in the model, including electrocardiographic LV hypertrophy, LV systolic dysfunction, having a thicker carotid IMT, having a low ankle brachial index, or microalbuminuria indicating chronic kidney disease. And notice it's a little bit weaker, that relationship, but she couldn't make it go away. So there's some special sauce here to cardiovascular health that's working through pathways perhaps beyond what we think of as the traditional working through biomarkers, working through subclinical disease. And so we were able to look at this again in Mesa using a very similar approach. We had maybe a little bit more robust data, and one of our fellows, Tammy Polonsky, looked at this. And again, we see lower event rates in the people with high cardiovascular health scores. We see that 67% lower risk unadjusted. And then when we adjusted for subclinical cardiovascular disease measures and biomarkers, including the coronary calcium score, the left ventricular mass index, and the carotid IMT, you can see we couldn't knock it out. Still a 50% lower risk for people with high cardiovascular health versus low cardiovascular health, even though we were using kind of state-of-the-art subclinical disease measures to try to knock out this association. So those pathways, working through, developing plaque, having more left ventricular mass, all those things matter in how cardiovascular health turns into cardiovascular disease, but they're not the only story. And I think that's kind of interesting. And so had the opportunity to kind of opine, well, what's going on here in relation to that first Xanthakis paper? And I think one of the, as I said, one of the tantalizing things here is that it seems like the package here, the whole, is greater than the sum of the parts. It's more than just not having risk factors. Maybe it's unmeasured aspects of healthy lifestyle that we can't consider yet in the models. Maybe it's the duration of time one spends with optimal cardiovascular health that really, really matters. And maybe it's that, more benign forms of atherosclerosis and more benign forms of aging that happen with high cardiovascular health compared with low cardiovascular health. But it's been fun to think about, why is this so powerfully protective as a phenotype? And why is it important to kind of keep as many of those parts of the package together as possible? Okay, so now you want to know, if it's really this good, well, how do I achieve and how do I maintain ideal levels of cardiovascular health? What are the determinants of maintaining cardiovascular health into midlife? Well, unfortunately, the population hasn't figured it out. These are data from the National Health and Nutrition Examination Survey. This goes back to 2007, 2008. It is no different today, I can tell you. But notice that by late adolescence, age 12 to 19, only about 40% of our youth have maintained at least 5 of those 7 metrics at ideal levels. and it falls off quite rapidly through the decades of our 20s and 30s, 40s and 50s. By age 60, only about 3% of people have maintained all of their cardiovascular health metrics at ideal level, or at least 5 at ideal levels. So it's falling off quite rapidly as the population ages. So the question for us was, if we're starting with higher or high-ish cardiovascular health earlier in life, and it's rare by midlife, is this genetically pre-programmed? Does it have to happen that as we age, we lose cardiovascular health? Or is there something we can do about it, right? Is our health behaviors going to help us achieve and maintain higher cardiovascular health? So went back to our friends at the Framingham Heart Study, and perfect setup here, because remember, they've got 3 generations of related individuals, all of whom have been phenotyped roughly in their 40s and 50s. So we can look at the cardiovascular health status across 3 generations of individuals, try to figure out, is this a heritable trait or not? We know that some of the components are very heritable, things like blood pressure, risk for diabetes, even weight. Those are heritable phenotypes. But this package of cardiovascular health, how heritable is that? And the answer we found was that if you look at just the clinical factors of cardiovascular health, wasn't that heritable? Significant, yes. But this suggests that 80+% of your cardiovascular health status in midlife is related to environmental exposures or health behaviors, and not so much to your genetics. And then when you add in the behavioral components of cardiovascular health, even lower heritability. Again, statistically significant, but it suggests that the main issue here is our environmental exposures and our health behaviors. So then we flipped the question. We said, okay, well, if that's the case, let's go find a cohort that can tell us whether these health behaviors can actually help you preserve cardiovascular health. So now we're kind of moving into this zone of that diagram I talked about, whether young adult behaviors and lifestyles can help influence your cardiovascular health status in midlife. And so going back to our tried and true Cardia study, we're one of the field centers for Cardia, so not surprising that we like to use it. What we did was we took people and followed them from, again, mean age of 25 at baseline to roughly age 50 when we did this analysis. We used those same 5 healthy lifestyles that you saw earlier to say, okay, if people were pursuing these lifestyles or achieving, these kind of health metrics, how did they do in maintaining cardiovascular health into midlife? So again, lean BMI, never smokers, no or low alcohol intake, DASH style eating pattern, and participating in physical activity at recommended levels. And what we found was, as you see here, across all the different sex race groups, that if you followed only 0 or 1 healthy lifestyle through young adulthood, you had about a 2% chance of making it to midlife with ideal cardiovascular health. If you followed all 5, you had a 50 to 70% chance of making it to midlife with ideal cardiovascular health, with a really nice dose response here, suggesting if it's not heritable, if it's not so much about your genes and DNA, maybe lifestyle can really help us achieve this goal of high midlife cardiovascular health, at which point we win the game, right? That's the fountain of youth. So I think a really nice study showing that. Just last week, really nice paper came out from the Atherosclerosis Risk and Community Study. I'm so glad I could incorporate it into the talk. So this is going back to that cohort, 45 to 64, people who identify as Black or white Americans. And they were able to take 8,600 individuals from this cohort. Again, mean age of about 54. They were followed for 26 years at this point. And they've got genetic data. So they applied the UK Biobank polygenic risk score, sort of the state-of-the-art polygenic risk score for cardiovascular disease today. More than 6 million different variants incorporated into this polygenic risk score. And they just said, okay, so if you're low risk, we're going to say that's the 20th, less than the 20th percentile of your polygenic risk. We're going to call high polygenic risk if you're in the 80th or higher percentile on this polygenic risk score. But we're also going to stratify people by their cardiovascular health score. And they used a point score that I don't love, but that's okay. They called poor 0 to 4 points, high or ideal 10 to 14 points. Notice in their version of ideal, you could smoke and have diabetes and still get called ideal cardiovascular health. So if you had 5 other things perfect, but had 2 things bad, you still are getting called ideal cardiovascular health. So I wouldn't necessarily cut the data this way, but they did, that's fine. Let's look at what the outcomes were. So then they estimated the lifetime risk for these midlife individuals. And notice that stratifying their polygenic risk score into low, intermediate, and high, there is stratification. The people with low polygenic risk had a lower risk for cardiovascular disease. People with high polygenic risk had the highest risk for cardiovascular disease. It worked. It should work, right? That we know genes play a role in your risk for cardiovascular disease. But notice the stratification when they stratified by Life Simple 7, those 7 metrics, even better stratification. The low risk people by cardiovascular health score are at lower lifetime risk. The high risk people are at even higher lifetime risk than those polygenic risk score individuals. Interesting. And I would make the point, this is probably an underestimate of the effect of the cardiovascular health score, because again, we've got people in the ideal category who we might not necessarily call ideal. So there's probably greater stratification than is being given credit. So then here are those horizontal bars looking at compression of morbidity. And I think this is a really nice aspect of their analysis, because they looked at both joint contributions of the polygenic risk score and the cardiovascular health score, the Life Simple 7 score. And so what I want you to focus on here is the difference between this top bar. These are people with low risk genetic score, but they have poor lifestyle. And the very bottom bar are people with high genetic risk and ideal lifestyle. So the question we're going to try to answer here is, does ideal lifestyle trump your genetic risk? And you can kind of get a sense for what's going to happen here, right? So notice that compared to this group with low genetic risk but poor lifestyle, the folks with high genetic risk, so we'd be really worried about them, but they're trying to do their best with their lifestyle. These people, 18-year longer health span, 18 more years on average without cardiovascular disease, 11 years longer lifespan. They're going to live longer to see their children graduate and their grandchildren graduate from high school. 7 years less on average with coronary heart disease. Major compression of morbidity. So what this really suggests to me is that these lifestyle factors in cardiovascular health can trump pretty significant amounts of genetic risk. And that's a very important and I think a very hopeful message for our patients. Yes, you may have a strong family history, but if we do this right, starting at a young age, we can trump almost all of that genetic risk, which is pretty remarkable. Okay, I think you've gotten the points here. In the interest of time, I'm not going to rehash all of this, but I think you get it because I would just want to get to this last little section. Is this something we can pass from moms to babies, from parents to children? So we're going to focus now at this very top part, just in these last few slides. And I want to share with you some data that have been coming out over the last year or so from one of our cohorts here, the Hyperglycemia and Adverse Pregnancy Outcomes Study. Large international cohort of women enrolled in their second trimester of pregnancy. The initial purpose of this study was to look at and redefine what gestational diabetes is, to understand where that threshold for diagnosis should be. But fortunately for us, they captured most of the variables in the cardiovascular health construct. So we could start to look at mom's overall cardiovascular health, the pregnancy outcomes for the mom and the baby. And then we had a follow-up exam for these individuals, mom and baby, 10 to 14 years later as well. How is the cardiovascular health status of those kids doing based on how mom looked during her pregnancy 10 to 14 years earlier? Kind of a fun way to be able to look at this. Not surprisingly, women with poorer cardiovascular health in pregnancy had worse pregnancy outcomes. So women with 2 or more poor metrics in their cardiovascular health score, much more likely to develop preeclampsia, have an unplanned primary C-section, have a high birth weight baby, low birth weight, a little bit more complicated to dig into. The babies had more adiposity and they were more insulin resistant at birth based on what mom's cardiovascular health status was like in the second trimester. 10 to 14 years later, moms with poor cardiovascular health were 8 times more likely to have children with poor cardiovascular health compared to moms who had high cardiovascular health during pregnancy, who were 8 times less likely to have children with poor cardiovascular health. Now, there's 10 years in between here. There's a lot of stuff going on in the home, but it starts to make you wonder, is that intrauterine environment really important for programming the potential for higher cardiovascular health in these kids? And that's where I want to finish up. So if it's not the DNA, and I've made a case that DNA is important, but it's certainly not the main thing that's helping us launch and maintain cardiovascular health. If it's not the DNA, what could it be if there's some heritability here? And the answer, we think, lies in our epigenome. So we all inherit our DNA code from our parents. That's fixed at birth, largely. But there are other things we can do to our DNA that determine whether we can switch genes on and off. So if you can't turn a gene on to express it, it doesn't matter what the DNA code is. And that's what the epigenome is doing. It regulates gene expression. And often that's done through methylation groups that get placed at certain points in the genome. And especially if they're at hotspots in the genome, they can determine whether that cell can actually turn on or turn off a gene. So think of this as the DNA is the Christmas tree, and the methylation pattern on top of the DNA is all the ornaments, if you will. Okay, it turns out those ornaments are heavily influenced by our environmental exposures and our health behaviors. What we're breathing, what we're eating, what we're drinking, what we're exposed to in our daily lives determines where those methylation groups and how many of them get deposited on the surface of our DNA strands. Okay, so one way to think about this is biological aging. There's sort of clocks in the genome where methylation gets added at a somewhat more predictable rate. And those are related to, as I'll show you, our health behaviors. So people who have more methylation at certain points in the genome are biologically more aged than people who have less. And so we can compare that to their chronological age and say, this person is epigenetically older than their chronological age, or this person is epigenetically younger than their chronological age, and then create this thing called the Grimm age score. And what we found again in Cardia was that for each 1 point higher cardiovascular health score in young adulthood, age 25, that was associated with about an 8-month lower epigenetic age. So every 1 point higher in your cardiovascular health score, didn't really matter which of the cardiovascular health metrics we were looking at, was associated with an 8-month younger biological age. And we replicated that very nicely in the older Framingham cohort as well. Really kind of an interesting way to think about this. And then last point, when we look at the patterns of methylation in our Cardia participants, there are certain pathways that seem to be particularly important. And what we showed in this study was that there were 3 particular genes of interest where methylation seemed to explain, at least statistically, about 20% of the variation in coronary artery calcification and about 28% of the variation in left ventricular mass. So happy to talk more about that if there are questions. I would just want to finish up with the thoughts that I hope I've convinced you cardiovascular health is a really important goal to aim at with our patients, with our families, with our communities, and that I think we as physicians, clinicians, and advocates, we have a lot of tools in our toolbox. With our patients, of course, if our patients have risk factors, we need to do everything we can to mitigate the risk of those risk factors. But starting younger and younger, getting people focused on those healthy lifestyles, giving them the tools to improve one thing at a time. They don't have to attack all 7 at the same time, but improve one thing at a time can be incredibly important. And primordial prevention can be remarkably powerful at reducing lifelong risk for all sorts of chronic diseases of aging. And I would also encourage all of you to use your voices in your schools, in your communities, with your state legislators. This seems daunting. As I have the privilege of being the president of the American Heart Association this year, I can tell you it is incredibly rewarding. Legislators, our community, our metropolitan commissioners, they are so hungry to talk to people knowledgeable about health and to do the right thing. And so if you want to be an advocate, you can kind of get some of the tools at you'rethecure.org. It's the American Heart Association's advocacy website. Many other ways. Please feel free to reach out to me. I'd love to connect you with people. This is the way to have the fastest impact on the most people that we can. And your new colleague, my friend and colleague, Mark Huffman, who's just joined you at WashU, is one of the best advocates I know. And so you've really gained a tremendous person who can help with these kinds of activities as well. So I want to stop there. So grateful to have been invited to give the Guller Family Lecture. Hope I've convinced you about my passion, at least for cardiovascular health, and maybe activated you to be a little bit more active in promoting it as well. Thank you so much.
Dr. Lloyd-Jones, thank you very much for a fantastic talk and for very much honoring the Guller family. Let me go ahead and share my screen here while I start posing some questions to you. Here we go. Great. So we have first, let me just start with a comment from Keith and Cindy Guller. And they say, thank you, Dr. Lloyd, for your discussion presentation. Very good representation of the correlation of cardio risk factors to cardiovascular risk, and the composition of CV morbidity analysis shows longer heart health lifespan for those that take more positive life heart optimal factors. They said it was of particular interest to the focus on prevention of RF development in children and younger adults and how we can achieve cardiovascular health in a middle life. And last resort, doctors should carry a 2x4 to get these points across.
You know, whatever it takes, right?
Whatever it takes, absolutely. Let me start with a question for you from Dr. Mann, who asks, can you comment on how assessment of inflammation fits into the paradigm of life's simple 7? If a patient has maximized lifestyle but has a high CRP, is that high CRP still a risk marker?
Yeah. So it's a great question. And, you know, no question that, and I didn't have time to dig into the details, but in that Framingham analysis by Vanessa Xanthakis and the analysis by Tammy Blonsky, no question that cardiovascular health status was associated with inflammatory markers like CRP, like some of the ICAM and VCAM markers as well. So no question that these are related concepts, that, you know, the better your health behaviors, the better your risk factors, the lower tends to be your inflammatory burden. So I think those are useful markers at the population level to tell us that inflammation is an important part of the story, and absolutely it is. CRP is tricky. I have to admit, I've never been a huge fan of CRP as a something that helps us with decision making, because it's so variable day to day in patients and can be influenced and elevated by a number of factors that are not directly related to vascular inflammation. So I don't find it to be that reliable, and I also find that I can predict somebody's CRP pretty well just watching them walk in the door. If their waistline enters before they do, their CRP is going to be high. If they're older, it's going to be a little bit high as well. If they smoke, it's going to be a lot higher. So all those things kind of tell me I don't really need to measure their CRP. But you bring up an interesting point. What about the person who's got a healthy lifestyle and yet has a high CRP? And I think the answer is, I often try to probe a little bit deeper if I have those data, because that's the question I get, is there something about the lifestyle that's not optimal? Or oftentimes, especially if that CRP is over 5 or definitely over 10, there's something going on that's either autoimmune or inflammatory, that is either related to joints or some sort of other autoimmune dysfunction that I think is very important, because again, that amount of inflammation certainly can potentiate the risk for developing atherosclerosis. So I think you need to individualize in those patients, take a deeper dive on their lifestyle, but also understand, could there be something else going on that I haven't detected in terms of their immune function or other inflammatory cascades?
Well, Dr. Huffman adds his thanks for your presentation and asks, can you discuss policy options that improve cardiovascular health, especially strategies to address upstream commercial determinants of health? For example, you mentioned the $75,000 difference in Medicare costs between individuals with high versus low cardiovascular health, but can we quantify the externalities from unhealthy industries and adjust taxes and incentives appropriately?
Yeah, and Mark knows this is an area of particular interest for me, so it's a bit of a softball. I appreciate that. And the answer is yes. We can't do multiple randomized controlled trials of communities, unfortunately, where we implement a policy, in one community, we don't implement another, and then we're able to look at the direct cost estimates. But we have pretty good data, and we are getting increasing data about the incredible power of things like tobacco excise taxes to reduce the incidence of smoking, particularly in youth, and how that influences health outcomes and health expenditures. We know clean indoor air laws, where we don't let people smoke in restaurants and bars, are associated with dramatic reductions in hospitalizations for heart attack among smokers and non-smokers in those communities. And when those policies get rescinded, it goes right back up again. So these natural experiments, I think, are quite informative, and they can tell us about some of the costs. And I think the current frontiers for us are continuing to push tobacco endgame, pricing kids out of the market for tobacco and, yes, nicotine products like e-cigarettes and vaping to make sure they don't get hooked. That will have significant health savings for us down the road. Sugar sweetened beverage taxes early in the natural experiments, but looking promising in places like Philadelphia, in places like Berkeley, California, where we see significant reductions without losing business, by the way, but significant reductions in sugar sweetened beverage intakes in the target populations, particularly our youth. So there are really good data about how policies can influence health and reduce costs. But, you know, are they at the same level of evidence of a randomized controlled trial? No, and we'll almost never have them. But, you know, I think we need to encourage our policymakers to do these natural experiments. And, you know, they can feel confident they're going to get good outcomes from them if they're well designed. And there's lots of playbooks about how to design these policies.
Great. Dr. Dimitrenko thanks you for your talk as well and asks, you know, you powerfully showed that the intervention is best when applied early, oftentimes at a stage when a person is maybe being seen by a pediatrician. But a lot of these changes are likely require the family to change, not just the child. From a clinical standpoint, how do you tackle this? How do you approach the whole family when you're seeing just one member?
Yeah, it's a wonderful point. And I think that's exactly right. You know, I just want to emphasize, it is never too late to change. There are always benefits to change at whatever age you implement it. But you're right, the earlier the better, no question. And I think that, you know, there are some really terrific programs that have been demonstrated. And I think that the grabbable moment, the teachable moment is that pregnant mom, maybe it's a preconception visit, maybe it's right after birth. Moms get healthcare in this country. This is the time we need to grab them and take advantage of that so that we're launching mom into a healthier trajectory post-pregnancy, and we're launching the baby into a lifelong healthier trajectory. So, you know, working with our OBGYN colleagues, working with our pediatrician colleagues to try to get the whole family launched into a healthier place, I think is critically important. But you know, as internists, as specialists, you know, I'm a cardiologist, I think we all need to be doing this with our patient every time. Encourage them to bring their spouse so that we can develop a plan for healthier eating in their house together. Because you're right, it's going to fail if they try to do a one-off and the rest of the family isn't on board. So I think there are tips and tricks. I think there are strategies. But for me, it goes back to the policy thing. Let's tilt the playing field so that the healthy option is more often the default option. It's cheaper to buy fruits and vegetables than it is to buy McDonald's, for example.
Yeah. Well, I think with that, you know, we're about out of time. Let me again just echo our thanks for you being here. Thanks to the Guller family. Thank you for all your work in preventative cardiology. And thank you for bringing Dr. Stamler to our attention. Sounds like a fantastic man. And you know, I know you've done him a great honor with your work and talk here today. So thank you very much for being here, sir. And thank you to Dr. Mann.
Thank you, John. And thank you, Doug. And again, thank you so much to the Guller family.
Great. Take care, everyone. Thank you very much for joining us.